Okay, well, welcome to our lecture this morning. Looking forward to having some conversation. I say that kind of conversation in quotes. We all know that it's a little bit difficult within the context of a Zoom meeting to actually have a meaningful interaction with the little 2-inch faces and often no faces at all on our screen. But this is a topic that can be very emotionally laden for some folks. When we start talking about death with dignity and aid in dying and different characterizations of that particular practice. And I'm really would like to encourage the fellows and faculty to look at this morning's lecture as just a starting point to launch conversation that you all can have within your own programs face to face. I think it's really important, especially for the fellows, to begin addressing the issue, knowing how to talk about the issue, knowing the language that's important, of course, and also to come to grips with how they personally feel about it, so they can be prepared to address it. Because regardless of where you sit on the fence, either side or on it, on this issue, you will almost certainly have need for engaging the conversation in response to requests for hastened death amongst your patients and families. So with that prologue, I share the screen here. All right, so hopefully you all are hearing me just fine and you've got the slides in front of you. So we're going to begin talking a little bit about uncertainty because I think a lot of our approach to folks who are experiencing end-of-life issues, there's a lot of uncertainty that is wrapped around that whole process. So I want to talk just a little bit about that. So we're going to disrupt some expectations that medicine can offer certainty. And that knowledge will cure our uncertainty. We're going to identify some actionable responses to the uncertainty and discuss some opportunities to live meaningfully despite having to live with uncertainty. And then we're going to understand the role for aid in dying and voluntary stopping of eating and drinking at the end of life. So no disclosures that I have relative to the content of this. There are a number of ingrained myths in medicine. And I think one of the most ubiquitous, and I think sometimes dangerous, is that science gives us answers, certainty, and a guarantee, and that knowledge saves us from uncertainty. Many of you who are older will recall 25, 30 years ago, there was a very, very popular and actually successful ad campaign by University of Michigan Medicine at that time that simply stated knowledge heals. And I remember watching that ad and thinking, you know, within my patient population, there are a lot of people that know a lot, we know a lot, and they are not going to be healed. They are not going to be cured, and that could be a little frustrating. They follow that up with a recent ad campaign called Michigan Answers, and let's see if I can, if this goes right, I can show you this. I apologize. I had this set up nicely, but clearly it's not working right. Okay. So anyway, the thing about this particular ad campaign is that answers are advertised and promised. It also implies that if we can do something, we must. It also implies that technology relieves suffering. And there are a couple of things that I do agree with that ad, and that is that people do want certainty. Patients want certainty, families want certainty, and the doctors want certainty. However, our human experience is to have to live with uncertainty. That's the reality of our particular circumstance and situation. And despite the promise of answers, our patients encounter a messy, tangled world, conflicting voices, unknown causes, and indeterminate futures. William James is a philosopher of pragmatism, and he notes I think appropriately that certainty cannot be promised. The solution to uncertainty is not knowledge. Solution is action as a risk of faith. I'm not talking about religious faith here. I'm talking about faith in a system, faith in a process, faith in people. Faith with uncertainty, we need to have faith that a step forward is going to produce something positive for us. And so
John,
we
I'm
need to
gonna
have
interrupt
faith.
for a second. Are we supposed to be looking at your slides now or still at the YouTube channel? Because we see the YouTube channel up.
Oh, I'm sorry. Yep. Thanks for pointing that out. Let me see if I can bring the slides back. Okay, we're back there?
Yep, got it now.
Great, okay. So, it just was, yeah, there, so that the solution is not knowledge, solution is an act of, is a risk of faith. And it's not something to fight. We really can't fight uncertainty, but we can become part of what makes life meaningful as we live into life's mystery. And I think that's an important concept as we ourselves face uncertainty, as we help to guide our patients and families through uncertainty, is that this is the reality, and we, rather than trying to fight it, to really embrace it as we move forward. With respect to the concept of hastening death, patients with advanced illness, sometimes, I might even say often, request that physicians help to hasten their death. And among the death hastening options, the spotlight has been on primarily what initially was referred to as a physician-assisted suicide, has now gone under other titles: physician-assisted death, death with dignity, and medical aid in dying. And I would suggest that medical aid in dying has become the more popular and most used terminology in the literature at this particular point in time. Another option is voluntary stopping of eating and drinking, which is also a course that patients may choose. And we're going to talk about both of those as we kind of course through our time here this morning. Clinician participation is critical in terms of initial assessment and ongoing management. And we'll explore some of the underlying ethical and legal considerations for physicians who either care for or decline to care for these patients. The point, as I mentioned before, you can't escape this. This is going to be part of your practice. And so you need to understand how you feel about it, how you react to that, and how you're going to respond to patients who ask for this. Physicians who care for seriously ill patients should be prepared to respond to patients' requests to participate in those interventions. And again, I want to be careful that I know we've got folks that believe strongly both sides of this. And so this doesn't mean that you need to prepare to respond by participating in the interventions, but you need to be prepared to the patient's requests. And you need to kind of formulate your position and how you're going to assist them with the issues that they're dealing with. So just some definitions: VSED, which is voluntary stop of eating and drinking. This is when a cognitively unimpaired person deliberately renounces food and fluid with the aim to hasten death. Now, there are certainly circumstances in which our population, in which patients have lost the desire. They have lost the urge, their appetite is waning, often as a result of the disease process itself. But this is a little bit different, in which someone is making an intentional decision to stop eating and drinking. Physician-assisted death. This is where a physician helps the person end his or her own life by giving advice and writing a prescription for lethal medication, or assisting the individual with some device which allows the person to take his or her own life. The physician lends the expertise and the resources, but the person themselves actually carries out the act. So physician works as a facilitator there. Other definitions that are important in this regard: voluntary euthanasia is when another person, out of compassion, does an action with the intention of ending the life of the suffering patient at his or her request. So the patient either no longer has the capacity physically or doesn't want to. They want their life to end, and they request that of the physician. The physician then carries out the act. Non-voluntary euthanasia is a compassionate act in circumstances where the patient is unable to make a voluntary request. This might be someone who is unconscious, who's comatose, who has dementia, the adult, or an infant or child who by definition don't have decision-making capacity. And then there's involuntary euthanasia, which is a compassionate act to end the life of a patient who is perceived to be suffering and could make a voluntary request, but has not done so. Those distinctions between voluntary and non-voluntary and involuntary are important. They exist in some capacity in various parts of the world as legal opportunities. So it's important that we distinguish this from withholding, withdrawing life support. I think that we've been through this before, but there is no ethically relevant distinction between withholding and withdrawing. We talked about that, talking about helping our patients with withdrawal, for example. Both are questions of harms, benefit, and quality of life. Both are legally and ethically acceptable, and again, there is no distinction between the two. It is not assisted suicide, physician-assisted death, or euthanasia. And I would certainly, it's important to acknowledge that our decisions to withhold or withdraw do impact the timing of the death. But the death is always as a result of the underlying illness, not as a matter of our actions. Intention matters. And in these particular circumstances, our intention is not to kill, but to prevent harm and allow the disease to run its normal course. We've all seen folks for whom the sustaining of life, sustaining measures can be very, very harmful to patients and their families. So it is a differentiation between killing and letting die. And I just want to make sure everyone's comfortable with the concept that withholding, withdrawing, legal, ethical, and it happens frequently and should be a responsible alternative to folks who are requesting something like that. One of the first Supreme Court cases was Vaco versus Timothy Quill, 1997. And they state that when a patient refuses life-sustaining medical treatment, he dies from an underlying fatal disease or pathology. But if a patient ingests lethal medication prescribed by a physician, he is killed by that medication. So that's Supreme Court ruling that constitutes a component of the law of the land. We should probably talk about continuous deep sedation. It has undergone a number of terminologies, as that last bullet indicates: palliative versus terminal versus controlled sedation. The evidence suggests that controlled deep sedation hastens death. People die sooner if they're completely sedated than if they were not. I've seen studies that argue that point, but I think the preponderance suggests that people will die sooner if you totally and completely sedate them and remove their nutritional support. And the question, and I'll talk about double effect a little bit more, does the principle of double effect apply in this particular circumstance when you are providing sedation in this regard? And it sort of depends. Is unconsciousness or death the only means to symptom relief? If death is intended as the means, then it counts as killing. And the concept of double effect does not exonerate because the intention is to kill someone. If the intention with sedation is not to kill someone, but just to put them in a state of unconsciousness so that they no longer are suffering, then that is considered both legal, ethical, and moral. Again, the terminology, some people, we don't really use the term terminal sedation anymore. The two most common ones are controlled sedation, palliative sedation, and then some people use continuous deep sedation on that also. So let's say just a couple words about the principle of double effect. Is it ever morally acceptable to administer a drug that may hasten the patient's death? I would argue that we do that all the time. There are drugs that we provide patients that have, serious and significant side effects for which death is a possibility, but that's not the intention. The intention is that the drug would produce some other positive benefit to the patient, but we have to accept the reality that death could be a consequence. And therefore it does not count as a suicide or an assisted suicide. I will just parenthetically, the kind of the sine qua non of this in the literature has always been the providing morphine to a terminally ill patient. And I just want to go on record as objecting to that characterization, because the way that we use and dose morphine, it's hard to imagine that morphine itself would ever cause death in someone, unless you were, they're opioid naive and you're giving them a tremendously large dose, which we, within our practice and within our standard of care, we don't do. So you can use other examples, but if you're going to talk about the principle of double effect, I probably wouldn't use the morphine example. So there is an act, and you have the intended effect, and you have the potential unintended, but a potential effect. And so there is a morally distinct difference between the intended and the unintended effect. So with respect to conversations about the double effect, it always has to do with intention and what is our intention on what we're doing. So let's translate that into physician-assisted death and how that brings us more contemporarily. But we go back in history. The ancient Greece and Romans tended to be tolerant of the practice. Hippocrates represent the minority view, and I don't know if they do this anymore. I probably would defer to my younger colleagues, but when I graduated from medical school, 267 brand new physicians stood up and recited the entirety of the Hippocratic Oath, which includes the line, "I will neither give a deadly drug to anybody if asked for it, nor will I make a suggestion to this effect." So that goes back thousands of years. And historically, our major religious practices, Christianity, Islam, Buddhism, Hinduism, Judaism, is opposed to suicide and endorse the Hippocratic view. So that's the historical context. And in fact, under Jewish law, the directive to preserve human life generally outweighs other considerations, including the desire to alleviate pain and suffering. They have that in their practice, the sustaining of human life outweighs pretty much everything. Physician-assisted death is now legal in 10 countries, Switzerland being the first in 1942, so it's been a while. It took 60 years for others to come on board. Netherlands and Belgium, Luxembourg, Colombia, Canada, Austria, New Zealand, and Spain. And most recently, Australia legalized that as a country in 2022, just 2 years ago. Physician-assisted death is legal in 11 states, technically 10 states in the District of Columbia: Oregon, Washington, Montana, Vermont, California, Colorado, Washington, District of Columbia, Hawaii, New Jersey, Maine, and New Mexico. Oregon was the first. And since 1997, which is now 27 years, 26, 27 years, there have been 5,300 deaths recorded by under that law. So about 200 a year. In contrast, and it's always an interesting note, that there are great multiples of individuals who receive the prescriptions for that never exercise the option. And to that, I would say this is based on death certificates. And what the literature doesn't relate is what the statistics are as far as physicians who have provided that prescription. The prescription has been taken, but the death certificate relates something other than an assisted death. I know that happens. I just don't know the extent to which that happens. But we have at least 200 a year that are documented. If we go a little bit further down the slope, euthanasia is now legal in Belgium, Canada, Colombia, Luxembourg, the Netherlands, New Zealand, Spain, and Australia. So they have said beyond just the assisted death, we will allow other forms of of euthanasia to be legal in these particular countries. Also, you need to be aware, because I would tell you that for a lot of physicians who feel uncomfortable with the process, there's a niggling in the back of their mind that says, yeah, sort of relieving suffering seems to be a good thing for us to do. But I feel uncomfortable with the prospect of providing a lethal prescription to someone, and have said, well, my out is that it's illegal in the state of Michigan, so I can't participate in that practice. You're not going to have that to lean back on for very much longer. There's legislation introduced in the Michigan legislature in November, so just 3 months ago, which has been dubbed the Death with Dignity Act. All the sponsors are Democrats, and as for those that follow Michigan politics, know that we have a Democratic House, Democratic Senate, and a Democratic governor. And the expectation is that this will pass sometime during the current year, probably after we've got 2 House seats that are up for special election. In November, 2 of the Democratic representatives were elected mayors in their towns. And so abandoning their role has now given the House an equal 50-50 split between Republicans and Democrats. So this is going to come down to political issue. Here are some of the points that have been put into this: a required medical determination that the patient is terminally ill with fewer than 6 months to live. I find it fascinating that virtually all the states that have this as law have gone to the hospice regulations and the determination of a 6-month prognosis. We know from previous conversations that that was an arbitrary number, and yet that has now wound its way not only into law, into financial coverage for end-of-life services, but now into our assisted death and euthanasia conversations as well. And I would ask the question, why 6 months? What's the magic about 6 months? That will be the law, but I don't know why it seems to be an arbitrary number. They need to ensure that the patient is voluntarily making the decision to die. There is a minimum 15-day waiting period. The law requires access to insurance coverage for the treatment and benefits regarding this practice. There are some licensing requirements and limitations and protections for prescribing physicians. There are also criminal penalties for physicians who participate in the practice but are non-compliant to the law, and there are criminal penalties for that. And they have put those in as safeguards for just willy-nilly use of that. I also want to just make a parenthetical comment here. There is talk about, usually in whispers in the back hallways of hospitals, about physicians that have in the midst of illegality of hastening death, at the hands of the physician, kind of a wink and providing medications, sometimes in inordinately high doses that can be justified on the basis of science, in quotes, I will put that, but they know there's no case in the patient's death. So there are suggestions that some aspect of physician-assisted death occurs already. It's just never talked about, and it's never acknowledged as such. And it just suggests that physicians themselves have some sensitivity to the patient requests for hastened death. So what are the motivations for hastening death in this particular way? The ones that we hear most often are loss of autonomy. I need to be in control of my life. Some have their sense of loss of dignity, inadequate pain and symptom control, depression, and the fear of suffering. And I want to just pause on the fear of suffering bullet just for a moment. Within the literature, we don't have strong data that suggests which of the of these 5 bullets or others is a predominant factor that motivates people to seek a hastening of their death. This is my own personal experience, having been around for a while with this, is that virtually every time that I have someone talk to me about this, it is the fear of suffering that motivates that. They're okay right now. They're feeling good. They're in good, stead, but they have seen people suffer at the end of their cancer diagnosis. They have heard of the tragedy of progressive ALS. They have been on the internet and have corresponded with people who are arguing for getting out before it's too late. Too late being when the ravages of the disease are now such that life is intolerable. But in personal experience, it is the fear of suffering. And I only point that out because some of these things we can't do. If the loss of autonomy, I would say, sure, if you got someone who's end-stage ALS, there's a lot of autonomous capability they have lost. We would hope that they have maintained a loss of decision-making within their autonomous decision-making. But there's a lot they can no longer do for themselves. And for some, that represents a loss of dignity, and it's not a way that they choose to live life. So just in terms of understanding those, again, my overwhelming preponderance has been the fear of suffering the patient. Go ahead, Jay.
John, and likewise, and almost all of those up there, loss of autonomy, those are all forms of suffering, right? Suffering is practically infinite, and it's unique to the patient, to their loved ones, right? To each and every one of us. Something that for me is suffering may not be for you. And thus, you can almost change that slide to all of those as form of suffering, and then the fear of suffering more, right?
Sure.
And thus the double effect, if our goal is to relieve suffering, that gives us a lot of space to operate with confidence, ethics, and whatnot.
So, those are the motivations. Oh, more on this slide here.
Yeah.
Abandonment, perceived burden on family. That's a big one. And I'll come back to that in just a second. Self-image, how people see themselves and their role within their community, their family, and losing the sense of who they were, who they are. Prospect of long-term care. And we've seen that from patients who are insisting that their children never put them in a nursing home. Don't ever send to be one of those places. And finances, and that's a real thing also, in terms of what is going to be the financial burden on my family to persist within this disease state for much longer. The perceived burden, and I use the word perceived intentionally because it's what the patient themselves perceives. And I often would have a conversation with them to say, your spouse, your children are adults with decision-making capacity. And you may think it's a burden for someone to care for you and attend to your personal needs. They may see it as an act of service or an act of love, and something that they are desperately wanting to provide to you. So before we just jump into, well, I don't want to be a burden on my family, let's talk about what that means to them. And then let's engage those people who you feel are going to be burdened by that, see what they feel about that. I think it's an important conversation to have when we think about the burden issue. So our state became famous 30 years ago with Dr. Kevorkian, who felt that this was an important opportunity to offer. There was some conversation as to whether or not what he was offering was actually assisted suicide or voluntary euthanasia. He had a van that was equipped with a machine that would provide carbon monoxide to his patients. And he would take it a step further. In one report that I read, there were 69 patients who died with Kevorkian's assistance who were autopsied by the Oakland County Medical Examiner. And according to the autopsy reports, only 25% were terminally ill, according to the autopsy findings. 72% of the patients had a recent decline in health status that may have precipitated their desire to die. So, and this was Kevorkian's argument. He would say, so what? If someone doesn't want to live anymore, shouldn't we as medical practitioners provide them a humane way out so they don't have to go in the garage with a gun? You know, is it considered legal and ethical? If assisted death is considered legal and ethical, is it essential to have a terminal diagnosis or a limited prognosis to engage practice? Someone's experiencing some element of suffering in their life. Do we have the responsibility of helping to tease out what is the underlying cause of their suffering, or can they define for themselves what suffering is? So the laws will put the put boundaries around that, and they will, in most states right now, and if this passes in the state of Michigan, have to have a terminal diagnosis and a limited prognosis. But it's just for conversation. If it is considered legal and ethical to hasten death, what is the purpose of having a terminal diagnosis or limited prognosis? And why would that matter? So the main arguments for assisted death, we talked about this. Number one, on the ethical side, well, killing is not always murder. It's, they use pejorative terms sometimes. Things like self-defense, warfare, capital punishment are examples in which killing is considered justified. Assisted death is a respect to the patient's self-determination and their life closure goals. It relieves the patient's suffering. If they are having abject suffering that cannot be relieved at that particular point in time. Safeguards can mitigate abuse, and those are the pro arguments. The con arguments, that it is not our right as physicians to facilitate death. We have spent our careers and our education learning how to identify broken things and fix them, and that the giving now physicians the right to end life corrupts the traditional role of the health provider. Some feel that it'll erode trust. I'm trusting that my physician has not only my best interest, but my ability to respect and preserve my life. And now they have within their hands the capacity to prematurely end life. It does risk abuse, and there's a slippery slope. The Netherlands is the prototype for that, but now that other states have come on board, especially Canada now is sort of the poster child for the slippery slope, from going from allowing an assisted death to euthanasia. And so it's now gone beyond just a patient taking an act and the physician facilitating that, but the physician actually carrying out the act. So those are some of the con arguments against it. There are some ethical and legal points as well, because there are a lot of people who believe that assisted suicide may be justified, that it is in fact an ethical process. And the Vacco versus Quill case in '97 was exactly that sort of a thing, in which Dr. Quill argued that it was justified in this particular case. It's an interesting process, and if you want to spend some extra time reading to look up that case, Dr. Quill, this was started by an article that he published in the New England Journal of Medicine, outlining how he helped a patient end their life, and that resulted in a bit of a furor. But his argument was that it was justified because of the patient's circumstance. So it doesn't just, we know that there's a distinction between ethical and legal, and just because something is ethical doesn't mean it should be legal. And conversely, just because something is legal doesn't mean that it's ethical. And we can further confuse that there will be a lot of people who feel that once it's legal in the state of Michigan, it will be legal, but may not be moral. And then there's the, just in the background, if you have recalled any of your ethics training and the difference between deontological and utilitarian ethics. Utilitarian ethics quite basically states that the ends justify the means. And what if something, what would the consequences be if something became a general rule? Or as my wife often tells her 3rd and 4th grade special ed students, what if everybody did that? And the boundaries become blurred and the guide rails become a little bit frayed. So what should be our response to a hastened death request? Well, the first thing we need to do is assess the biological, psychosocial, and spiritual suffering underlying the patient's request. As I mentioned, my experience is that it is the fear of suffering that dominates these conversations, not universally, but it's very, very common. And more importantly, explore the patient's fears and distress and honestly explain what can and cannot be promised. Things we can do and things that we can't. And the clinical team should redouble the palliative efforts to address the patient's concerns. And then if the patient continues to be interested in last resort options, clinicians should discuss which are legally available and which that the patient or which the clinician can personally support, and where they can receive those resources if the physician doesn't support it. And that's a fine line there that other people will argue against, that if I morally think that this is wrong, I have no obligation to refer the patient to someone who will carry out an act that I am personally opposed to. But this day and age, I think that if patients are asking, we need to be honest with them. That's just kind of part of our responsibility as a physician. So it just, this is how we do this in terms of looking at the opportunities to relieve the suffering and to alleviate the fear of suffering. I came across this this comment the other day, and I just thought it was interesting. The issue really isn't patient autonomy or their right to make decisions about their bodies and lives. It's about giving the medical systems and their doctors, with its flaws, prejudices, biases, societal and political influences, and the power to screw things up, the right to kill. And so I contemplate that. I also, have been humbled by patients who are in the midst of what I would interpret to be, significant burdens on their lives, of a disease burden now that I'm speaking of. And they have been through very, very difficult circumstances. They're facing the reality of the end of life. Their lives are much different than they thought that they were. By our interpretation, if that were me, I think that would produce a lot of abject suffering. And yet their comments to me are, you know what, I wouldn't wish this on my worst enemy, but I wouldn't trade it for the world. What I've learned about myself, what I have learned about my family and my friends and my community, the way that they have rallied has been amazing, and I have appreciated what has happened as a result of this illness. Things that they would not have experienced necessarily had they exercised their right to hasten their death. Or as one patient told me in the midst of her terminal metastatic cancer, she's told me, she says, I feel like I'm in the eye of a miracle. And that just struck me. And I think there's a lot that people can learn. There's a lot they can experience. And I think that to the extent to which we can allay the fear of suffering and actually abjectly relieve suffering, we give them the opportunity to experience aspects of life. So I'm exposing my bias, but that's just as a result of as much my experience as it is a belief system. So related to this, I think it's important to understand the principle of voluntary stopping eating and drinking. From initiation to death, VSED has a very distinct time frame for patients and families to come together, say goodbye, and work on life closure issues. The initial states of VSED are really largely under the patient's control. They can choose to eat or not to eat, drink not to drink, and how much and how little or none at all. Clinicians really are needed to be part of the process to continue to assess the patient and help manage symptoms that may go along with stopping eating and drinking. I would say that in many circumstances, if not most circumstances, because of the nature of advanced disease processes, trying to deal with hunger is not as much of an issue because patients in the end of life often have some element of anorexia. But that can be mitigated if that's an issue for the patient. How you mitigate a thirst if they're feeling thirsty. But the bulk of the process is patient-driven and patient-executed. It is not tantamount to suicide. It is chosen voluntarily. And these are some of the ethical issues. Is it tantamount to suicide? My answer is no, it's not. Is suicide always morally wrong? I'm not going to get into that argument, here in the 15 minutes we have left. There are circumstances in which I have seen suicide in patients who were living with extraordinary circumstances that you would look at, and people are grateful for the relief of the suffering they were experiencing. But I would say that those that I have seen, those were not terminally ill patients. So unless you consider depression to be a terminal illness. Is VSED chosen voluntarily? Well, it should be. If it is, there's no ethical issue with it. And do clinicians who believe that suicide is morally wrong have an obligation to participate in the care of patients who choose VSED? Well, I don't believe that VSED is suicide, and I think that the preponderance of literature would suggest that as well. Someone is choosing not to eat, and usually they're choosing not to eat because they're looking to end their life, but it always is in the context, in my experience, that I've seen it, in the context of an imminently terminal illness. So, and do physicians have an obligation to inform the patients of this option? I think that if patients are requesting a hastened death for any reason, that we as clinicians should inform them that this is an option that's available to them, because it is considered legal. Well, let me back up on that. Go to the next slide. The ethical issues, it rests on a spectrum of normal end-of-life patient behaviors that few would equate with suicide. There are a lot of people that stop eating and drinking, not because they're saying, I want to stop, end my life, but because I can't eat anymore. I can't swallow. It doesn't taste good. I just don't want to eat. And no one would equate that with suicide. Underlying disease process can impair appetite and thirst and prompt patient desires for a quick death. And before that VSED label, no one was forcing dying patients to eat or drink. It is fundamentally a patient-driven phenomenon and should remain so. It neither harms patients nor requires a physician's direct agency. Physicians can and should accompany patients who are dying from an underlying disease and tolerate their choice of VSED. The primary ethical rationale for tolerating VSED stems from an obligation of non-abandonment of the dying, rather than promoting patient control or even minimizing suffering. We're going to walk with patients regardless of what they choose, and we have all walked with patients who make decisions about their care, some of which we agree with, and some that we may not agree with. What they're choosing to take, what they're choosing not to take. Someone who has a curable cancer, an adult who has a curable cancer, but chooses not to take the chemotherapy, deserves our non-abandonment also. We must walk with these patients, even though they've made decisions that technically hasten their death. Because VSED is patient-driven, the categories associated with clinical informed consent are not germane. And I guess if a patient does not have a terminal illness and chooses to stop eating and drinking, how does that change the conversation? And I guess that's again an interesting twist on that. Is that motivated out of depression, out of something else? So if we put this into a chart form, and this chart I took out of an article. I can't see the citation on the bottom. It was an older article because it notes that it's only legal in 6 states. But here we look at medications such as opiates for severe pain dyspnea used proportionately. That is legal and ethically accepted. Although I would argue that necessarily doesn't deserve to be on this chart, because used proportionally, it shouldn't be an issue that would result in hastening death. Stopping or not starting life-sustaining therapy, certainly, as we've talked much before, is legally and ethically acceptable. Palliative sedation, potentially to unconsciousness, is legally accepted. It's ethically controversial if the patient or physician's intention is to hasten death. Voluntary stopping eating and drinking is not illegal, although interestingly, its legality has not been tested. And it can be ethically controversial based on some of the things we just discussed. Physician-assisted death, also known as assisted suicide or medical aid in dying. It's legal in now 10 states, District of Columbia, all of Canada, and is ethically controversial. Voluntary active euthanasia is illegal in all US states. It is legal in Canada and is ethically controversial. So that kind of takes you through the continuum of options that we have available. This was a comment that I made during a broadcast almost a decade ago. It was a news segment on Channel 13 here, in which I was asked by the news anchor what the Trillium Institute was doing to help to facilitate hastened death for the Grand Rapids community. I was kind of taken aback. That was not to be the conversation that we were going to have, but this was within 2 weeks after Brittany Maynard had ended her life in Oregon, having moved there from California, because California did not at the time have a Death with Dignity Act. So she moved, established residency in Oregon, and then ended her life there. And so they asked me that, what the Trillium Institute was doing. And my comment to them was that I think it's tragic that anyone would wish for death because of fear of suffering. And then I went on to comment about what the Institute does in terms of educating both the medical community and the lay community about the opportunities to relieve suffering and to address the fear of suffering. I also did not give that anchor a chance to ask another question because I wasn't sure what else she was going to ask. But I would guess that when at the end of the day, I believe in this comment that for someone's fear of suffering to motivate that has to be a tremendous amount of fear that they have. What have they seen and experienced that makes them that fearful, that they think that their only rational option is death? So I think that it behooves us as a hospice and palliative community to be sensitive to the fact that people are going to be questioning this. There's that old a movie decades ago, They Shoot Horses, don't they? Which is, I've seen as an argument for why we should allow this practice. I think that's it's not a fair analogy. But I do think that we have to be very, very upfront about the reality that patients have a fear of suffering, and some are abjectly suffering. And we need to make sure we're doubling our efforts to do that. So that is it. I will stop sharing there. And we've got about 5 minutes before we transition to our case. So I'll just see, does anyone have any questions or comments? Again, difficult to have a meaningful one-on-one dialogue, but James, I see your hand up there.
Oh, can you hear me okay?
Yeah, I can hear you. Yep.
Okay. I'm sorry. I lost sound for about 6 minutes. So if you showed this quip before, I'm sorry, I'm repeating it, but Woody Allen had a famous quip of he wasn't afraid of dying. He just didn't want to be there when it happened.
Exactly. Yep.
And one of the things I've just learned in my career from experience backing up, when you talk to more and more, I've come to appreciate patients' distress has been until you really discuss with them, they're afraid of being a burden on their family. But they've not talked to their family about it, and they have a lot more support than they would have expected. So I just sort of found in my career, I put a lot more emphasis into that about asking about, are they afraid of not having support or being burdened? But beyond that, I sort of found as a derivative, another thing, if they have to go talk to their family about this, then they have to reveal to their family how sick they are. And that's another hesitancy that they don't want to have people worry, or, or families are shocked when you discuss this, that they didn't know how things were going on. So I always found there was a great benefit to discuss, what do they think it's going to be for their family? Have they discussed it for their family? And does their family know what their status is? Was this going to be sort of a shock for them? So just my thoughts on it.
Hey,
Other
John.
question? Yeah.
Ken Hansen.
Hey,
Just
Ken.
a couple quick comments. First, I want to applaud you. Your comment at the start of the lecture about encouraging people to pursue further training, education. I think that we run into these moral issues in our clinical practice. And if a clinician doesn't understand where they stand morally, ethically, then we're not in a position to help our patients and families. Sorry, turn this off. The other comment is that there was a recent article. I wish I could have found it to include in the chat, but it was a study looking at the states that have legislated MAID, medical aid in dying. And it looked at the hospice agencies and how they informed the patients and families of that option. And frequently they did not. So for the folks on this call that are going to be dealing with hospice patients, I think it's going to be good to have a protocol on how you're going to have to address that issue as a treatment option once this becomes law in the state of Michigan, which it probably will.
Yeah, it probably will. And I think it just emphasizes a need. I appreciate your comment, Ken, about understanding what we feel about it. I know that in Oregon, there are hospices that actually, as part of their marketing, promote that option as available to the patients that come into their hospice organization. There are also those that have very distinct moral objections to that, and they state that too, which I think that as an agency and as a practitioner, you need to know where you stand if you are going to be able to be honest with your patients. But I think that you need to have the conversations, be prepared to have the conversations, and I'm very careful about this, not to diminish the patient's request or what they're feeling and sensing, even if you are significantly opposed to the practice. You don't want to alienate the patient, but help them, you want to understand where they're coming from, so you can best help them. But trying to argue with them, I'm not sure is ever a productive process.
If I could finish or follow that up, John, to the fellows, everyone on the call here, taking advantage of this opportunity to be able to kind of discuss these things in in a broad forum with a lot of experience. Because again, a lot of us, we gained our experience. A lot of times it felt like walking in the dark, right? So just to have people to bounce these difficult discussions off of. And like what Ken said, I can't stress that enough. You can't lean in with your patients until you have first leaned in with yourself and your own personal values, and where do you keep that in the realm of professionalism, ethics, legality, etc. And it's evolving, right? And once you can do that, then you can, with confidence, again, stand in that space with your patient and hear them, not just listen to them, but really hear them. And so many times just hearing, listening to, validating. When someone tells you, I would rather die than bankrupt my family, early in my career, I would say things like, oh, don't worry about that. At this stage of my career, that is incredibly valid. And when I simply say, wow, just validating them, letting them know that that is a normal feeling. And then our job now is to help lean into what is the source of the suffering, and to borrow John's phrase that he learned from his patient, help shepherd them. They're in this incredible storm. And if we can, sometimes just by listening and validating, help shepherd them into that, what I have a miracle. Is that what the line, John?
Yep, I just, it's a blessing to be in the eye of the miracle is what you told me.
Storm's still going on, but there is a space within that maybe they can get to greater acceptance.
So we're at the bottom of the hour. I do want to just, there were a couple of direct messages here that I'm just going to comment. It had to do with the Michigan Senate bill. And does the term non-compliance relate only to those not wishing to comply to the determined rules, or also those who do not wish to participate in the process at all? No, it only relates to those who choose to participate in the process but don't follow the rules. That's the non-compliant issue. The other part of that is there a component of the bill that requires some form of psychiatric evaluation before the process to unfold. They do reference the fact that it should not be done if someone is experiencing depression. It does not require psychiatric assessment to that regard. They would anticipate that the practitioners would be able to assess whether someone's depressed and to obtain appropriate psychiatric or psychological intervention. In other words, it shouldn't be done on someone who carries a diagnosis of depression. But it doesn't require psychiatric evaluation. So
that's what I was wondering, because I think Switzerland and Belgium, they require neuropsych testing. If I can be wrong, I have to look up again.
yeah,
They're not in the US. We don't require it, right?
I don't know of states that require that, but they do mention that. But they're not saying you have to go see psychiatrists.
Well, there was the physician can request it in.
I'm sorry, say it again, Jody.
There are states that the physician can request it as a condition of approval.
Sure, it can request it, but I don't know that it's required.
No, not required.
Yeah. Go ahead, Melissa.
Well, that was one of the questions that I kept thinking about is like depression as suffering. Because there was a case I read about, and it was not in the United States, but it was fairly recent, with a younger person who had long history of depression and did find someone they carried out, I don't know if it was physician assisted or if it was euthanasia.
They found some way to.
Yes. So I was wondering about that whole issue. as, you know, if somebody's depressed, that it wouldn't be, you'd want to pursue treatment for the depression, but what about those cases where somebody has, you know, an intractable depression?
Sure, I just, since you brought it up, I'll just quickly mention a case that came to us in ethics many years ago. And it was a gentleman closing in on 60 years old who has had a lifelong history of depression. Had 3 or 4 suicide attempts, had multiple psych hospitalizations, had medications, counseling, had electroconvulsive therapy, everything you can imagine. And so he winds up in ER with yet another suicide attempt. He had a DNR order, had a durable power of attorney, one of his family members. And this time, he was now requiring life support and by everybody's determination would not survive. So the question was, is it okay to honor his DNR and withdraw life support? At which point, sometimes you need to be careful about engaging risk managers and lawyers because they, said, well, no, you can't because it's against the law in the state of Michigan to complete a suicide. So clearly the correct, the moral, the ethical thing to do would be to say, this guy, it needs to be relieved from his suffering. And there's nothing that we're going to do that's going to change his current medical outcome. So of course it would be appropriate to withdraw his life-sustaining measures at that particular point in time. So, and it gets back to one of the bullet points we had is suicide always, ethically and morally wrong? So that's a conversation for another day.
Yeah.
Well, thank you all for your participation. And at this point, we will then go ahead and transition to our case presentation. I'll yield the seat.
Sure.
Dr. Dimestein.